First question to you is, how many of you have ever treated somebody or taken care of somebody in withdrawal? Okay. So how many of you, that was a good experience, the person was well maintained on their meds and really didn't get into trouble? Okay. How many of you have taken care of somebody who went into a delirium because of alcohol withdrawal? Okay. So today I'm going to talk to you all about the neurobiology of alcohol withdrawal, because in order to act in the best interest of the patient and to be able to talk intelligently to physicians and pharmacists, you have to know what's going on in the brain with alcohol withdrawal. This is an incredibly common problem in hospitals. I will spare you the obligatory objectives, although I could read each one in a monotone if you want me to. But in essence, I'm going to tell you about withdrawal, what to expect, about the medications that you can use, which ones are good for withdrawal, and which ones may be prescribed but have no place in alcohol withdrawal, and how to handle that. So we'll talk all about the different presentations. We do have a policy for this. Now, I'm on the alcohol committee, and sometime in 2019, things will change, but you will hardly notice it. Right now, we have two different protocols going on for alcohol withdrawal. We have the protocols that Harrison, Highline, and St. Elizabeth uses, and then we have the protocol that the Saints use. And I had a dream that sometime, we would all be on the same protocol. And I've had that dream for the last 10 years. So it is happening before I retire, because I retire in 2 years. So I'm a happy woman. And so I'll be talking to you about how to manage those protocols, and some of the drugs that go along with that, and how to make sure that the interests of the patients are met. So we have known that alcohol is a problem for some people for thousands of years. So Pliny the Elder was a scholar and a physician, and he lived in the time of Vesuvius and Pompeii. He lived in Pompeii, and he was killed by the eruption of Vesuvius. But even then, he knew that for some people, being drunk, and this speaks to long-term drinking and trembling hands to withdrawal, that there was a syndrome that surrounded abrupt cessation of alcohol for some people. You can also get Pliny the Elder beer in Oregon. It's a craft beer. So the problem for alcohol withdrawal is immense in our hospitals, and they estimate that for trauma victims, over 50% of trauma victims have the chance that they will go into alcohol withdrawal. I always have to kind of silently roll my eyes when I'm listening to the news and they, have, a huge head-on collision and there were all these things and people were driving on the wrong side of the road, and they always say, alcohol may have been a factor, and I'm like, alcohol is most probably the factor in all of this. So the problem is also that we don't always recognize what is happening. So when I worked in detox, my challenge was to figure out what wasn't withdrawal. Your challenge is to figure out if the symptom that these people are having is withdrawal, because some of the symptoms can be confused with some other thing for which that patient is in the hospital or for some other complication. So that is your challenge. The protocols for treating alcohol withdrawal vary widely across the country. So you can go different places and they will have totally different protocols. There are some similarities though, and the similarities are that for the most part they use benzodiazepines, and now the current trend in alcohol withdrawal is to try to use gabapentin, and I'll talk about that and why you'll find out why that is being used. And so we went from a trial to having it be an option for our physicians here at CHI Franciscan Health to use. We have a protocol, and it can be only used for mild to moderate withdrawal because it has to be an oral medication. There is no IV gabapentin. So there is no single severity scale. We use the CWA scale, and I'll speak to that. Many, like the VA, uses a completely different scale. The CWA is used across the country, and it is far from perfect, but I'll talk about how to deal with its imperfections. And if you don't do it often, it's difficult to gain expertise and experience with this. So my challenge to you is, how many of you are is anybody a brand new nurse? Nobody's a brand new nurse, okay. So my challenge to you as you're in your practice is, if you want to get good at it, and some nurses don't want to go near it at all, and that may be you, but if you have an interest in this and want to do it well, offer to take those cases that you know where there'll be an alcohol withdrawal situation, and you will learn by experience how to do this well for your patient. So this is the definition of alcoholism that we're going to use. Adversely affect the mental or physical health of the patient. It can be either or, and this is the one that's used in the United States. So how many of you think back to your college days, and for some of you that was last week, but think back and think about the people you knew that couldn't seem to have a good time unless they got hammered. Have you had that, where you could count, if there was a party, this person was going to get drunk? It was just a given. Mm-hmm. Now think about those people, and think about people that you've been watching drink, and you say to yourself, I could not drink that much and still be standing up. And these people are still moving and talking. Have you known people like that? Okay. Well, that is a dangerous path that they're going down. Because that means their brain has become habituated to alcohol, and it has changed. Their neurobiology is now changed, albeit on a temporary basis, but it has changed, and that's called tolerance. And often this progresses to a dependence on alcohol, and if you have abrupt cessation of alcohol, like, gosh, you were in a head-on MVC, and now you're in the unit, that cutoff of alcohol can precipitate withdrawal. And about 70% of alcohol-dependent patients have alcohol withdrawal within about 6 hours. Now, I have known some people who could not go 3 hours without beginning withdrawal, but 6 hours is about right. Now, when we talk about how many drinks somebody has, let's talk about what is a drink. A drink is what is up here. So, in the ER, when we get people in and, they've been in an MVC, and we're trying to figure out where they are on their alcohol intake, it was like, how much did you drink today? 2 beers. It was always 2 beers. So a lot of times they're talking 40 ounces. That is not 1 beer. 1 beer is 12 ounces, like a Coke can, okay? And now, in restaurants, I watch waitresses bring out wine like in a vat. They need somebody to help them. These gigantic glasses. That is not 1 glass of wine. 1 glass of wine is a small tulip-shaped glass of wine. So all of these are equivalent, okay? So when you go to Epic, and on that social history, they will be asking you will be asking patients how many drinks they have in a week, how many drinks they have in a day, and you're going to be looking at that. So right now, this is what we refer to as moderate drinking in the United States. However, there's just been a huge conference, and now they are putting, this will be changing, to say that there is no safe level of drinking. So I would still keep in the back of my head this kind of guideline, because it is doubtful that you will get people who really don't drink at all. I mean, most people I know and I socialize with will have a drink maybe on a Saturday with a nice meal or when they go out and things like that. So I do want you to kind of think about this when you are working with patients. So heavy drinking, 5 or more times a month, and they drink it usually in under 2 hours. That's a lot of alcohol. And if you can do that and still be standing, you have a problem. But I know people who have to drink a minimum of 2/5 a day in order just to stay out of withdrawal. Not to get drunk, but to just stay out of withdrawal. So you will be surprised. So binge drinking is a repeated pattern of that heavy drinking. And it usually starts on the weekends because a lot of people work and they won't do that during the week because then they couldn't function. But on the weekends, they will develop a pattern where they drink a lot, a huge amount on the weekends and get drunk. Sometimes often it begins to spill over into problems on Monday. So these people will develop an absentee problem on Mondays for this or not be very functional on Mondays. Actually, binge drinking is the worst kind of drinking for a fetus. You'd think that it would be daily drinking, but it is binge. When they have that heavy episode of a huge amount of alcohol, whatever is being formed on the fetus then, it has a chance of being grossly malformed. So binge drinking is really bad for pregnant women. Any drinking is really bad for pregnant women. So when we talk about alcohol withdrawal, it's like, well, what is it? Well, it's a syndrome. It's a constellation of symptoms that occur. And it is all about the fact that your brain has adapted to alcohol and now it doesn't have it. And you are in complete adrenergic stimulation that has gone haywire. There is no break to your adrenergic stimulation. So the 2 receptors that are chiefly implicated on that are GABA and glutamate. Those are the big 2. Now the other 2 are associated with the feel-good part of drinking. So most of us have had a drink. Have you all had a drink at some point in your lifetime? You know, my family has such a problem with alcohol and drugs that I did not allow myself to have a drink until I was almost 30. And then I waited for the earth to cave in, to find me in a gutter with a bottle of Ripple. But it didn't happen. I just didn't get that gene. And I think it is because my sister did get the gene. And she's had a tremendous problem with alcohol. And we had different fathers. So many times the genetic propensity for alcoholism is passed down from your father. So, GABA is a receptor with a channel that lets chloride through that inhibits the brain, and glutamate, the NMDA receptor, is your excitatory receptor. So, GABA in your brain is the red light in your brain. It calms things down. It calms your brain down. Glutamate excites things. It speeds neurotransmission as opposed to GABA, which slows it down. So here is what is happening in your brain with alcohol intake and alcohol withdrawal. So GABA is a neurotransmitter, and it crosses that synaptic cleft. Bet you haven't heard that since nursing school. And it latches onto that GABA receptor, and it's able to lock onto that. And when it does, it opens a channel. And when that channel opens, chloride goes down. And who knew, but chloride inhibits the brain. It calms the brain down. It slows neurotransmission. Now, this GABA receptor here also will accept lots of other things to open that channel. It'll accept alcohol, it'll accept opiates, will open that channel. That's why you get sedated when you take these things. That's why when you drink, you get sedated, why opiates sedate you. It'll latch onto benzodiazepine, propofol, etomidate, which we sometimes use to intubate people. And all of those things can latch on and open that channel. So, when you are chronically drinking, this is constantly going on because you have all this alcohol in your bloodstream that is latching onto these GABA receptors in your brain because it crosses the blood-brain barrier. And so these chloride channels are constantly being opened and your brain is becoming sedated all the time. So over time, the brain says, look, we're drinking a lot now and we're constantly, sedated. I can't seem to wake up. We gotta wake up. And so what can I do? And so the body says, I know what you can do. You're getting alcohol, which is opening up that channel. So we're going to stop making so much GABA as a neurotransmitter because you got the alcohol. You don't need that. So it really almost shuts down the GABA production, okay? It also says, Mr. Glutamate receptor, I want you to act more. So I am going to make more glutamate. So it'll latch onto that NMDA receptor. And that'll excite the brain because it too has a channel, and when it lets potassium and calcium through, and it excites the brain. Okay? And that is referred to as neuroadaptation, and that's tolerance. That's why people can drink a huge amount and still be standing, where you can't drink the same amount because you're still making GABA. And if you stop this all of a sudden, you get alcohol withdrawal. And so a lot of withdrawal and alcohol metabolism takes place in a couple of places in the brain. So the VTA area, that's your feel-good area. So they found that people who are overweight, right here, and really like to eat, that area sometimes lights up on a PET scan because satiation is a feel-good thing for us. Orgasm is mediated there in part. And endorphins and cannabinoids are mediated there. And that nice pleasurable sensation of alcohol, rising blood alcohol, is mediated there as well. Your prefrontal cortex is your executive function. And that's the kind of thing that, prevents you from acting out all those id-like emotions. It prevented me from just crashing my car this morning into somebody else who couldn't seem to merge properly around the horse. So my executive functioning was saying, that's probably not a good idea, Vicki. So we all know that as you drink, you get stupid. And it screws up your executive function. There's a lot of alcohol metabolism that goes on there. That is also a place where a lot of alcohol withdrawal is mediated. That and your hippocampus and your amygdala. And this is your brain in a pictorial sense. So this is what everybody's brain looks like. Your brain always wants to be balanced, has that, wait for it, homeostasis. Another thing you haven't heard since nursing school. But between sedation and awake, it's always a balance between that GABA and that glutamate. But if you have too much alcohol and you're still making GABA, you've way tipped the balance. So with that adaptation of, slowing down the GABA production and amping up glutamate, and you keep giving the brain alcohol, you're again balanced. So alcohol withdrawal is unrestrained noradrenergic activity. And this is the thing that leads to all those outward signs that you see. What are some of the signs that you have seen in alcohol withdrawal? Tremor, a tremulous, right? Okay, anything else you've seen?
Insomnia.
Insomnia. They usually look quite amped up. They can't sleep. And if people will tell you, I feel like my thoughts are just racing through my head, what else would you see?
Hallucinations. Yeah.
Now that's a late sign, and you don't, with a straight withdrawal, you should not be seeing that. That falls in another category that I'm going to talk about. Irritability, people get nauseated, they get diaphoretic, and that is all that adrenergic stim that has no break now. And delirium and seizures should not be part and parcel of a mild to moderate or even a severe withdrawal. That should be outside of that, and you're losing the patient if you see those things. But that is because of autonomic hyperactivity, and that CNS just blows a gasket and you have a seizure. So this is the kind of thing that you will see in this alcohol withdrawal symptom. Almost everybody who goes through withdrawal goes through that autonomic hyperactivity. But this is not a linear progression, okay? It's not like, oh, step 1, autonomic hyperactivity. Oh, step 2, now we're going to hallucinations. It jumps around, and hopefully they never get here, okay? And again, it's not a linear progression. So this is what you'll see. People are tremulous. I have seen fine tremors to such gross tremors that they cannot feed themselves or comb their own hair, okay? People have a little sheen. It starts with just a little sheen of sweat, and if you let that unmedicated go on, they will be drenching their sheets so that you have to change their linen a couple times during the shift. Vital signs. Now, vital signs are not in the CWA scale, but we use them extensively when I worked in detox. People who are in withdrawal are tachycardic, so it's not unusual for them to have like a pulse of 120 to 130, and they are hypertensive. Not unusual to see a blood pressure of 180, 190, over 120, 130. And as you are medicating people and as they are getting adequate medication, you should see that come down, okay? Nausea and vomiting, very common. And people will say, even if they're not vomiting, my stomach feels jittery. My stomach feels jittery. I feel like I'm going to throw up, okay? But this, for people who have mild to moderate withdrawal, it peaks at about 48 hours. And a lot of those people, PO meds, a few PO meds, and we're good. You know, we can handle that. But that's generally speaking not the type of patient that we see in the hospital. Those kind of people often are long-term drinkers that have a bad withdrawal, and they have a lot of comorbidities along with the alcohol withdrawal. Because a lot of times they're in here for something else. They're having a coli. They're here for sepsis, whatever they're here for. But to be called straight just withdrawal, this whole time this person has a clear sensorium. They can tell you just how miserable they are. They know where they are, they know what's going on, they know who you are, and they're completely clear in their sensorium. Okay? Hallucinosis is a weird phenomenon that you may or may not ever see. I have had some people who have a relative paucity of the hyperactivity symptoms, but they have hallucinosis on a fairly soon basis. And those usually, if you see hallucinations right away, that's going to be a rough withdrawal. That is going to be a bad scene. So hallucinosis can be visual or auditory. It can be tactile, but generally not. Tactile hallucinations go more with methamphetamine and cocaine. Okay? So visual and auditory, a lot of times it's animals. It can be animals that fly, like bats and things like that. They will hear things, and you will see, you're in the room with the patient. You're the only thing other than the patient in that room. And they start attending to other parts of the room. I automatically ask them, if I know that they're in withdrawal or sensitive, ask them about that. I say sometimes people, when they stop drinking, all of a sudden, see things or hear things. And it's very frightening. is that happening to you? Because we can give you drugs, medication, that will take that away, okay? So you may see that. Neuronal excitation is just a fancy name for seizures. And seizures will generally happen early on. And a lot of times families or the patient themselves thinks, I can handle this at home, and they can't. And they'll bring them into the emergency room or into the hospital, and they're way down their road in their withdrawal. They've been unmedicated, and the withdrawal has gotten away from everybody, and they will have a seizure. So here's something I want you to do. If you suspect that your patient might go through withdrawal for any reason, I want you to put on seizure precautions on your patient. So, on the side rails, all of that, seizure precautions should go on. And you want to make sure that that alcoholic patient does not fall down and hit their head, because they have problems clotting. So you don't want them banging their head against the side rails during a seizure, okay? So I consider that if I've had the patient for quite some time, and if they go from this to any of this, I think that we have failed them in some way, because they have not been adequately medicated. And I maintain that if people went into a delirium for any other reason other than withdrawal, it would be a scandal in the hospital. There would be process improvement teams trying to figure out why these people were going into a delirium. But I think all of us just sort of accept it as a given, and it doesn't have to be that way. A delirium for any reason is very detrimental to a patient. And a delirium for alcohol, your brain is not right for 6 months to a year. They've done neuropsych testing on people who've gone into alcohol delirium and survived, because not everybody survives. And the neuropsych testing is abnormal for up to a year. Now, I am going to keep hammering the give adequate medication, because we chronically under-medicate our patients, and we can prevent them from having this. And if you don't medicate people, alcohol withdrawal can kill you. If you go into a delirium tremens, 15% of those people die, no matter what you do. So one of the things why we need to medicate people are all the things that are written here. Unmedicated withdrawal, especially in people who are debilitated or older, and by older I mean over the age of 50, and believe me, I hate saying that. But those people, if they have the sequela of withdrawal, which means they go into AFib, their electrolytes are all disturbed. They have a massive amount of vomiting. They have, a delirium. That can permanently change things for their body. And it can lead to a thing called the kindling effect, which permanently changes the brain and makes sure that each subsequent withdrawal is worse than the one before it. And it can also lead to a thing called benzodiazepine resistance, where you are pouring Valium, Librium, Ativan into these people to stop their withdrawal symptoms, but the brain has changed so it doesn't lock on successfully onto that GABA receptor anymore. So it no longer works for their withdrawal. So we want to make sure that that does not happen. So when you see this kind of symptomology, jittery, insomnia, a slight tremor, diaphoresis, maybe a headache, and elevated vital signs, and you have reason to believe, especially because you see that tremor, that they are in withdrawal, start medicating them there. Now, our protocol says that we shouldn't medicate, that they don't get medication until they score at least an 8 on the CWA. And everybody in the alcohol committee all agreed while we were meeting that this is too late to start medicating, that it should be sooner. But because there was no literature on this, the physician and nobody was brave enough to say, let's start doing it. So, but there's no literature that says 8's the magic number either. What is this about 8? So here's what I'm going to tell you. When you are scoring them on the CLOS score, be generous in your scoring, okay? So if you think it could be a 7 or an 8, make it an 8, okay? Is it an 11 or a 12? Make it a 12. Be very generous in your scoring. These are late signs of withdrawal. And if you do not get on top of their withdrawal here, and they move to here, a lot of times you can't catch them. You can be sitting at a bedside in a unit, pushing, I've pushed all number of barbiturates and benzos and things, and a lot of times it's too late, you can't catch them, okay? So everybody wants to know what's the progression of alcohol withdrawal. This is a very, very loose interpretation because people are unique. So I would say that for the most part, when I worked in detox, mild to moderate withdrawal was completely over in 4 to 5 days. And they just needed some PO meds. And about 80% of people who go through withdrawal for any reason in any setting, that's them. You give them oral meds and they're good. The people that you're going to worry about are the people who start to have severe symptoms very early on, and the people who are still drunk and are having symptoms of withdrawal. Remember that people have built up a tolerance. So you are not going to wait to medicate people when their alcohol is 0. Because we breathalyze, in the ER we breathalyze people, and in detox we breathalyze. Because I want to know what I'm dealing with right now. And then I breathalyze them in half an hour, figure are they going up or going down or what's the story. And some people, I took care of a nurse, gigantic guy, they brought in from home in his plaid bathrobe to detox. And he blew on our Alka sensor a 434, and he was already in withdrawal. He was vomiting and tremulous because and he was working. He worked a job. He had a job because his walking around was like 500. But it took years of heavy drinking to build up to that. Okay. So I want you to be aware that they don't have to be 0 to medicate, but people who are exhibiting symptoms and still have a high BA, they're going to go through a rough withdrawal.
So this implies that seizures happen early.
Yes,
So
if it's unmedicated, it happens early, or under-medicated. Your withdrawal gets away from you, and it will happen early. It's very dangerous to have people go through seizures, especially if they're benzodiazepine resistant, because then you have to try to find something to stop their seizures. Dilantin does not work for alcoholic seizures. We generally try to stop it with Valium, Versed, all of that. And if they can't do it with that, we use a barbiturate to stop their seizure. Okay? Ativan, you can use Ativan for a seizure. You can use that for a seizure. Let me just say about Ativan for withdrawal. I prefer Librium or Valium because it has a longer onset time, and I've given you a chart in your handbook. But it peaks and it has a longer half-life, so it provides a smoother withdrawal. Ativan is more like this. Ativan is great when you have somebody who's got a bad liver. We use Ativan. It's the best drug for them.
Well, that's all that's on our CROC protocol, right?
No.
Is that it isn't?
No. Anyway, so mortality rate is at least 15% with delirium tremens. So we have people who go anywhere from no withdrawal, even though they're drinking quite a bit. I'm like, okay, I'm waiting for the withdrawal on this guy, and he never has it. Sometimes people surprise me. to anywhere to severe. And if unmedicated and they're severe, they'll be peaking around 48 hours and they can go into a delirium or have hallucinosis along with their alcohol withdrawal symptoms. So who is going to have a bad withdrawal? These are some predictive factors. If you are in withdrawal and still have a BA, a high BA, if you drink a lot, especially daily drinkers. So here's how to ask how much people drink. So you'll be asking them those questions about EPIC, but just like you would explore more pulmonary, if somebody had a history of asthma, you'd go beyond just whatever EPIC questions there are. Same thing with alcohol. And the way to ask a question about drinking is to normalize it. So I will say things like, so about, you like whiskey, so about how much do you drink a day? A fifth a day, 2/5 a day? Like everybody drinks that, okay? Because otherwise you're not gonna get an answer. If they're a beer drinker, I'll say things like, I don't know, a rack a day, half rack a day. How many? 3 6-packs a day, like everybody does that. Wine, bottle a day, 2 bottles a day, so that they will feel comfortable telling you what they drink, okay? Older age, after 50, people who have comorbidities, and that's who we see. They're in the hospital, for God's sake. So they have comorbidities. If they're in a debilitated or poor condition already, they'll probably have a rough withdrawal, multiple substances, and those people who have a pattern of daily drinking are more apt to go into withdrawal while they're here at the hospital. Delirium tremens is a whole beast unto itself. So what you need to avoid is to be calling bad withdrawal delirium tremens. Delirium tremens is just what it says. You're delirious and you're shaking, okay? The sailors, they used to call it rum fits when in the British Navy, because the sailors all got a ration of rum, and when that was cut off, sometimes people had quote-unquote rum fits. So you will see all of these things. Now, the thing about a delirium is it is a problem with being able to focus attention. So sometimes, especially in the beginning, this will wax and wane a bit. So you'll go in and you'll think, I'm losing this guy. He's not totally with me that he was an hour ago. And then you'll go back a half an hour and he'll seem better and you'll think, maybe it's just me. Maybe he's been like this the whole time. And then it will become steady. But I want you to get a baseline on how that person is the first time you see them, so that if they vary from that, you will be able to tell. And I want you to know that people can seem like they're following you a little bit, but if their attention wanders off, that's not a good sign. That's one of the problem with focusing attention. So, we had a patient in the ER. I'm in the ER, walking down the hallway, and I look into this room, and a guy is sitting, he's in his early 20s, sitting on the edge of his bed, and he has the classic ER look where the gown is hanging off one shoulder. And he's looking around the room and kind of moving, but with no purpose. And his poor parents were in there saying, Tommy, lay back in bed, get back into bed, Tommy. And I thought, oh my God. And he had a tremor. I thought, oh my God, this guy's in a delirium. And so I went to the nurse who was in that room. I said, what are you guys doing for the guy in 6? And they said, oh, we're going to send him home. What? And she says, well, he's directable. We'll send him home with some Ativan. And I said, show me. So she takes me into the room, and the guy's sitting up, so she kind of crouches down, and she says, Tommy, lay back. Is that how you talk to somebody who's 22? No. So he kind of gets back into bed, and there's 22 motions, and he kind of brings up half of the blanket, and in 15 seconds, he's right back up again. I said, that is not directable. This guy's going into a delirium. That is not directable. Went out to the doctor, and I said, we can't send this guy home. He's in a delirium. And he said, yeah, we're sending him home. He can't do it. So Tommy cured the whole thing by having a seizure. And then we had to admit him. So people, you should be able to talk to them normally, and they should react normally. Alcoholic seizures, if a benzodiazepine, you'll need to start pushing benzos, IV, and of course it'll probably be whatever you've been giving them. But if that doesn't work, then consider the use of a barbiturate such as phenobarbital or some other barbiturate. You can't let this patient continue to seize. And that's the time, sometimes anesthesia has to come up and stop it and intubate the patient. But generally speaking, if you give them an adequate amount of medication, they will stop seizing. But sometimes it's a lot of medication. Elderly cannot be allowed to go through withdrawal that's rough because we can't stand it. It's like running a marathon. You're sweating, you're tachycardic, you're hypertensive. A lot of times older people go into AFib. That's the dysrhythmia of choice for alcohol is AFib. A little catecholamine burst on that SA node, and it goes woo, and they go into AFib for a while. So people in this room, you guys, you young guys can tolerate it. If I went into AFib, I would lose, I lose to 25 to 30% of my cardiac output, and that may make me syncopal and all these other things as well. Old people have far fewer reserves, as do hospitalized patients. So here's kindling. Kindling goes on in the hippocampus, and it makes you resistant to benzodiazepines, and it also means every withdrawal you have will be worse than the one before it. That's why one of the things I ask with alcohol is, have you ever been in withdrawal where you stop drinking and you feel like crap? And if they say yes, I'll say, tell me what was your experience? What did you experience? And if they say something to the effect of, I don't know, I woke up in the ICU, it's like, well, I know what I need to know now. Or if they say, well, I just felt a little jittery and they gave me some pills and I was okay, then I know what I need to know. So again, poorly managed withdrawal, so under-medicating or no meds can lead to the change in hippocampus, and it leads to a permanent change in memory. And the end stage of that is a thing where people do a thing called confabulation. And that is, they have lost the long-term memory of their life, but their brain doesn't quite get that. So if you say, well, tell me about your family, the brain says, ooh, can't access what actually happened. Let's put in something fake. And they'll launch into a big spiel about their family and about their kids and things where they live. None of it is reality. But the brain has put something in that place. And that's called confabulation. So there's your questions for EPIC, and it's drug and alcohol use, and how much you drink a week, how much you drink a day, and there's a place for a comment, and sometimes you may want to be putting in there, oh my, but put whatever they tell you, especially if they tell you they went through withdrawal. I would put that in there to make sure that people know that they've been through withdrawal in the past. And there's right now in EPIC, these are your guidelines. Let me just tell you this. If there's any inkling that they drink this much, or if just on your gut, you're saying, I have a feeling this person might go into withdrawal, I want you to ask the physician to put on the chart to order the alcohol withdrawal order set. And part of that order set is just watching the patient. You're not forced to give any meds if they don't need it. you can just watch until they develop symptoms. So then at 3 o'clock in the morning, when that patient actually starts to have withdrawal symptoms, the night shift nurse will have that available to them, and you won't be calling some hospitalist who's never seen the patient, knows nothing about the patient, etc. Okay? There are some screening questions that I use as well, and I'm going to teach you CAGE today. I would also ask you to look at their history if you suspect that they might have gone through withdrawal as well, and their general condition. And so this is the CAGE test. It's easy to remember, and I've used it on thousands of people. Have you ever tried to cut down on your drinking? Have you ever become angry or annoyed when someone asked you about your drinking? Have you ever felt guilty about your drinking? And the last one is, have you ever taken a morning drink as an eye-opener to steady your nerves or get rid of a hangover? Now, a yes to any one of these is cause for concern, but if you get a yes to the last one, get loaded for bear. Because that person's going to have withdrawal and it's going to be rugged. I've known some people who cannot sleep 6 hours because in that amount of time they start withdrawal. And they have to keep alcohol at the bedside. It's the first thing they do is they have a drink because they're already tremulous. Okay? So then I start exploring all of these things. Okay, do you have the shakes in the morning? How long can you go before you need a drink? When I worked in psych, I had a tech that all of us knew this guy was a problem drinker, but we could never nab him for it. And he had to get out to lunch faithfully. He would get very upset if he did not get that lunch break right when he wanted it. And I knew from having worked in detox, I thought he has to go out and have a drink. So we finally got him on coming when he came back from lunch one time. We breathalyzed him, and he blew positive. But some people can't go 6 hours between drinks. And my favorite question is, when was the last time you can remember going a day without a drink? Now, number one, if they have to stop and think, then you've got your answer. But if they say, well, last month, I'll say, what happened during that period of time? And most of the time, I'll hear something like, I didn't feel very good. I started to shake, or I threw up, and I needed to take a drink again. So you got that, you go and get that order set on there for you. And you're going to start using the CWA scale because our order sets are all tied to the CWA. You do not need an order to do a CWA scale on any patient. You should be able to do that at any time on any patient. It's an assessment scale. Your CWA is in there. And so here is what I'm going to tell you are the good things and the bad things about the CWA scale. The CWA scale has many symptoms that people will exhibit during withdrawal, and you can rate them on a scale of, I think, 7. But a lot of these questions, people have to be completely coherent to answer. And a lot of times your patients, by the time you get them, either from an ER, from a med-surg, if you're working in the unit or whatever, are not able to answer questions. Or they have dementia, and they're not completely with it for another reason. They're septic. So you're stuck then. And you think, well, how do I score this? The other thing that I have problems with is this was never validated in a hospital. It was validated in a freestanding detox unit many years ago in the 1970s with young adult males whose only problem was alcohol withdrawal. So there you go. So it's very subjective. So here is how to work with this thing. Be generous in your scoring. Answer what you can with things, because some of them you'll be rating outward symptoms such as tremor. diaphoresis, things like that. Also, use vital signs. Look at the vital signs that have been going on this patient. To see, does it go down when I medicate, up between doses? What is going on with this patient there? Have your ducks in a row. Look at your patient. If he's in a delirium, then you know you're in trouble. When we talk to the alcohol committee, what the hospitalists and everybody else will be looking for, if you cannot do a valid CWA on this patient because they can't answer coherently or for whatever reason, they will be looking for you to tell them what symptoms you are seeing, because when you're calling them, you're requesting more medication or that they go to the ICU or whatever it is, and they want to know what's happening. So look at your patient and have that all ready to go. You know how you get stupid on the phone as soon as you call? And it's like, oh, what am I calling them for? Oh yeah. Write it out if you have to, but make sure you have that information available. Maybe they're very tremulous. Maybe they're beginning to go into a delirium. Maybe they're having a hallucinosis. All of that means they're under-medicated, okay? So we want to give them a safe withdrawal and a humane withdrawal. There is nothing dignified about pooping your own pants because you can't control your own body. And that can happen during withdrawal. So we want to make sure that we give them adequate medication. So you guys are on the protocol that these guys will be moving to. Okay? So all of you use it can be Valium, it can be Librium, it can be Ativan, depending on what they order. And the order set for that is what we will all be moving to. So there are a number of ways this can be done. I'm going to teach you two schools of thought because our gabapentin is CWA based, and some of the order sets for benzos are on what we call a fixed schedule. So symptom triggered is when you do the CWA score, you look at the CWA score and you say, the CWA score is 15. You look at the orders and they get this amount of med this frequently if their CWA is 15. Okay? And so that's very much dependent on the nurse. And it's what we call symptom triggered. Okay? Fixed schedule is just like it sounds. They get a med at this time, this time, this time, this time. Okay? Loading dose can be used with either. Now, if you do not get a loading dose and this person's already in withdrawal, I want you to ask for one. A loading dose is a nice, healthy, whopping dose of whatever you're going to use. And loading dose can keep somebody out of the ICU, out of a delirium. A loading dose is a very good thing. If you ever go to the ER, for God's sake, medicate people while they're waiting for their bed in med-surg, because all of you suffer because the ER doesn't medicate adequately. There are people who are waiting. And a loading dose can mean a huge difference for a patient. Here is that GABA receptor. And look at all the drugs that will open that channel. So barbiturates, etomidate, propofol, alcohol, benzos, and I couldn't find a picture with opiates, but also opiates have a binding site there as well. So for those of you who take post-op patients, sometimes people are being medicated for their alcohol withdrawal with a PCA pump. So just be aware that as soon as you cut that off, watch for any kind of emergence of alcohol withdrawal, if you suspect that. So benzos and barbs have been our drugs of choice up until recently. Barbs they use in Europe, benzodiazepines they use in the United States. Gabapentin, what does that sound like, gabapentin? GABA, right. That receptor is now being used for mild to moderate withdrawal. They had some huge trials, and the king of alcohol withdrawal, Jose Maldonado, who's a doc in California, trialed using gabapentin, and it worked pretty darned well. So for mild to moderate withdrawal. So now it's being spread across the United States, and we will have a protocol. We have it now, actually. They can actually order it now for what they call a benzodiazepine sparing, which is gabapentin, order set. I will be talking about some of the adjunct drugs as well. If you are in the unit, I am sure you have seen Precedex on people who are alcohol withdrawal. Have you ever seen that? No, only once? Let me just say this. Precedex has no GABA coverage at all. So if you end up using Precedex, you have to give something that is also, and this is the magic word, neuroprotective. Because if you don't, they will get weirdly sedated, but they can still go into a delirium and they can still have seizures because it doesn't have GABA coverage. So my response, if they want to use Precedex, I'll say, what? Great, okay, I'll take the order. What would you like me to use that is neuroprotective? Because Precedex, no GABA coverage. And so then you need some sort of benzo or barbiturate, something to give them GABA neuroprotection. These are the big ones: magnesium, potassium, phosphate, that get all screwed up on alcoholics. So watch those lab levels, especially. Neuroleptics alone should not be used because they increase mortality and they have no neuroprotection. So if you see Haldol ordered, Haldol really has no place in alcohol withdrawal. If people are having hallucinosis, they need more benzo or barbiturate or whatever they're getting. Haldol is great for hallucinations in schizophrenics, not in people having alcohol withdrawal. And not only, it lowers the seizure threshold, and it can prolong QT as well. So this is gabapentin, and this will be, you'll see this, I think, increasingly for those people who are taking PO meds. People do quite well on this. Now, the protocol that will be going into place, you'll be doing CWA and giving gabapentin according to the CWA score. It also has a provision that if the gabapentin doesn't work and they still have, you're giving them a lot of gabapentin and they're still having withdrawal symptoms, that you can give them either a one-time dose of PO Ativan or that it'll be switched to a benzodiazepine. So you need to call the doctor and be talking to them about this. It has a very good track record, low side effects. It's very cheap, which is good. And again, people do quite well. They can become a little sedated with this, but not like they do with benzos. And it has gabapentin also, it's an anticonvulsant, so it works against that seizure, any seizures, and it has anxiolytic properties as well. Again, I will not throw myself on my sword if they want to order this. I will give it. But again, I do say things like, well, I'm concerned because it lowers the seizure threshold, and what do you want me to give them that's neuroprotective as well? Clonidine you may use as an adjunct. It's an alpha adrenergic. It blocks alpha adrenergic symptoms. So the problem with this is it should only really be used if all of their withdrawal is in control, but dang if that blood pressure won't come down. But they have no other symptoms. Sometimes you'll see this order. But beware that this can mask some of the outward symptoms of withdrawal, which you're using to figure out how much meds they give. I spoke about Precedex. Again, use the magic word. What would you like me to give them that's neuroprotective? Beta blockers have no place in alcohol withdrawal. Some old-time physicians will sometimes use that. There's no place for that. It does nothing for the patient. It may stop them from having a tremor so much, but that's about it. It may lower their blood pressure a bit, but they're still having withdrawal, still going into a delirium. Now, do we give alcohol? Yes, much to my chagrin. But the physician may order it to prevent withdrawal. If it's beer, it comes up on the breakfast tray and it's ordered through dietary, because nothing says good morning like a beer with your post-toasties. But if it is hard liquor, wine or hard liquor of some sort, it will come from pharmacy. Now, my big concern with that is always that I would end up playing the bartender. It's like if they've been drinking 3 6-packs a day, one beer is not going to hold them. But I didn't want to be lining up beers, wiping out the glass, shooting the breeze while they figure out how much alcohol is going to do. So if that amount that's ordered doesn't hold them, then you need to call them and they'll go on a benzo protocol. Thiamine, give thiamine. If the liver has a choice between booze and thiamine, which is a B vitamin, it'll take the booze, leave the thiamine. If you are not given an order for any reason, get one. It's on all the alcohol protocol. You will either give it push or in a banana bag, that multivite colored infusion. Withdrawal can definitely get away from you and you can't pull it back. So who's on med-surg? Who's on med-surg? I am begging you to medicate these people. Because they drink a lot in large amounts, they are going to be taking a large amount of Ativan or Valium or Librium. Do not be afraid to do that. I want you to medicate them till they don't have symptoms. So I have what I call my pillow rule. When I had the day one with a patient in detox, I would medicate them, over time until their head was on that pillow. They were dozing lightly. And if I went up to them and tapped them and said, Mrs. Smith, they would open their eyes and say yes. They'd be totally with it, could carry on a conversation with me for however long I wanted to talk to them. When I walked away, they were awake. They may watch a little TV or whatever it is, and then they would drift back to sleep. That's the perfect situation for somebody in withdrawal. Okay? So that's why it's not just me, but many scholarly journals say that light somnolence is acceptable. Patient awake but tends to fall asleep unless stimulated. Okay? So I put in this slide because they make me. Oversedation is not a very common problem. I hardly ever have it with alcohol withdrawal. The one time a manager called me and said, and she was just so proud that she'd gotten me. And it's like, we had a case of oversedation after they went to your class. And I said, okay, what was said, who's the patient? What was the whole thing? Well, it was somebody they were giving PO meds to, and the nurse went in there and couldn't wake her. And they had a proviso that they could use IV meds if they needed to, so this nurse decided, because she couldn't wake her, that she would do IV push meds. And I said, I cannot solve this problem. This is not a problem with the protocol, okay? So under sedation, you will recognize it. People will be up, they'll be pacing, they can't sleep, the high vital signs, CWAS scores, they're not getting enough meds. It is not just drugs. Well, it's mostly drugs, but you also have to use your head with these people. They're scared to death, and they are thinking you're judging them, that you're not going to give them medicine. They've probably been through it before. Do frequent small assessments. You don't have to go in there and do the whole ball of wax, but you're on your way to see another patient. You've medicated this patient with whatever they're on. Know when that peak time is, and do a drive-by. How are you feeling? Hold out your hands. Is your stomach better? Okay, if they say no and they're worse, they're not getting enough meds. Then you have to do something about that. If they're on fixed schedule for medication, that doesn't mean that's the only meds they can get. If they're having breakthrough, it's just like pain med. You call and say, look, this is what's going on with this patient. They need more. Quiet environment, not a lot of stimulation. Be wary with patients, they cannot fall. People who are chronic alcoholics have very low platelets. So if they fall and hit their heads, subdural hematoma land, here we come. If you miss an IV, get ready for that huge balloon. So they have anemia, they're sick physiologically, so you need to be watching out for these people. Sitter if necessary, although if they need a sitter, you may be losing them in their withdrawal into delirium. Lots of fluids. They're perspiring all over the place. And be honest with the patient and tell them what you're looking for and how you will know and how you're medicating them, okay? Be honest with them. They need these meds. Always ask yourself, are they better, worse, or the same? Because sometimes those CLOS scores, you're like, I don't know, the last person got 11. Is he an 11 now? I'm not sure. Is he better, worse, or the same after you medicated him? If he's the same or worse, he needs more meds. Okay? If you do not get adequate medication, you have to go up the chain and make sure that you do. Night shift nurses, please wake your patient up once during the night to see if they're in withdrawal. Because you can sleep when you're in withdrawal. It's a restless, weird sleep, but you can sleep. But by the time you get up in the morning, you're way behind the power curve. So wake people up and see how they are. Call if you need to. If you don't get the meds that you need from the physician, talk to your charge nurse, talk to your manager, talk to the house supervisor. Do what you have to do to get these medications for this patient. Collaborate with the pharmacist, especially if they're benzodiazepine resistant. Pharmacist is your best friend. Call the pharmacist and say, this is a situation we have. I'm going to call the doctor about this. You know, can we put our heads together about what we can get for this guy, what would do best for him? Okay? And there are all my scholarly journals, so you can be impressed. Any questions? Okay. Do you feel like you're going to medicate people adequately? Yes, yes. No withdrawal symptoms. Ready for my close-up now.
Very nice.
Let's take 15.
I'm out.
And come back at 11.
If I could just get through boards.
That sounds like a novel. Get me through boards.
Oh, Elena, you did not have to do that. I love the soap. I smell the